So let me just go. Okay. So on behalf of my co-authors, I'll be presenting Revumenib monotherapy in patients with relapsed refractory KMT2Ar acute leukemia. And this is top-line efficacy and safety results from the pivotal Augment 101 phase 2 study. So previously used to called MLR rearrangement, KMT2 rearranged diseases can present either as lymphoid or myeloid leukemia, can be seen in children, infants, and adults, and represent around 10% of all acute leukemia. It's a disease with unmet therapeutic need. These patients high risk, they have high risk of relapse after transplant and after chemotherapy. And in adults, remission rates after relapse and median overall survival when the patient reaches second salvage therapy or beyond, it remains low. And it's the most common actual leukemia in infants, the KMT2 arrangement, and confirmed poor prognosis for this population. And as of now, there's no target therapy for KMT2 range disease. So Revumenib is a small molecule inhibitor of the menin KMT2A interaction, and currently is being tested in relapsed refractory KMT2 range, as well as NPM1 mutated acute leukemia, which is usually driven by the same menin KMT2 interaction. And the phase 1 portion of the study was reported already, and it shows that the drug has manageable safety and promising durable deep remissions in patients heavily pretreated with KMT2 range leukemia as well as NPM1. So the Augment 101 phase 2 study, so this is a study where included patients agnostic for age or the histology. So it enrolled patients as young as 30 days of age, and there was no upper age limit, and included two cohorts for the KMT2A, one for patients with ALL or acute leukemia with ambiguous lineage, and the other cohort was AML with the KMT2A. There was a third cohort, the NPM1 mutated AML, which is still actually enrolling at this time. And the primary endpoint was CR and CRh rate. And based on previous actually data looking how these patients doing, and the benchmark for the lower bound for the CR/CRh rate was 10%. And it was evaluated in patient. There was a pre-specified interim analysis for patients who can have documented KMT2 arrangement done centrally, and they have at least 6 months follow-up, or they discontinue the drug during that time. And that was the efficacy population for the study. So we have two populations here. We have the safety population, which include any patient receive at least one dose of Revumenib, regardless if they have the KMT2A checked centrally and confirmed centrally, and regardless of the follow-up. And you have the efficacy population, 57 patients, and these are the patients they were given enough follow-up, and they have the KMT2 range documented centrally. And it kind of representative, this study. You can see that you have quarter of the patients were children. There were 11% of patients were older than 65. There were 18% non-white. And the majority of these patients is acute myeloid leukemia, as we expect. The most common reported commutation was RAS. And we had quarter of the patients were refractory and never achieved remission, and over half of the patients were refractory to the last salvage therapy, regardless if they achieve remission before or not. And these are heavily pretreated patients. I mean, close to half of the patients, they had at least 3 or more prior lines of therapy, frequently had prior venetoclax, which is used frequently in AML, and almost half of the patients had prior allogeneic stem cell transplant, including 10% had 2 transplants before. So with a median follow-up of 6.1 months for the efficacy population, the overall response rate was 63, and the responses, you can see it on the right side. And the study met the primary endpoint with the CR/CRh rate of close to 23%. And with the p-value was significant as 0.0036, and the lower bound of the 95 confidence interval was 12.7%, which is above the 10% rate. And you can see the composite CR, which includes CR, CRh, CRp, CRi, was 44% in this heavily pretreated cohort, and of the patients who achieved CR/CRh who had MRD assessment, 70% achieved negative MRD, and almost the same number among patients who achieved composite CR. Now, after achieving response, 40% of responders were able to go to allogeneic stem cell transplant, which is usually our ultimate goal for someone with relapsed refractory leukemia. And half of the patients were able actually to continue revumenib as a maintenance therapy after the transplant. Overall, safety profile was encouraging, and the rate of drug discontinuation because of treatment-related adverse events was only 6%. The most common grade 3 or higher was neutropenic fever. With revumenib, as it is a differentiating agent, there's a concern differentiation syndrome, so it was 16% for grade 3 or higher. For QTc prolongation, another non-toxicity of revumenib, grade 3 or higher, was 13.8%. It's usually reversible. There were no patients discontinue revumenib because of differentiation syndrome, QTc prolongation, or cytopenia. In conclusion, revumenib is effective and safe in pediatric and adult patients with relapsed refractory KMT2 range acute leukemia. Revumenib induced durable MRD negative remission. I did not comment on the durability of remission. With the follow-up we have, the median duration of remission was 6 months. And there was high rate of transplant among these patients. 40% were able successfully to go to transplant. And discontinuation and dose reduction due to adverse events were low. And the study was stopped early after meeting the primary efficacy endpoint. The predefined interim analysis, a new drug application for KMT2 range leukemia has been initiated under the FDA real-time oncology review program based on this data. And we still have the NPM1 cohort ongoing at this time. We're hoping to have similar encouraging results as well. Thank you, guys.
Thank you, Dr. Aldos. So, wow.